have your audience. Thank you, Dr. Kelly, for joining us today and for having this session recorded as well. Dr. Ziam, over to you. Please start.
Okay. Thank you very much, boss, and good afternoon to us all. Welcome to today's presentation. We are talking about cervical cancer today. So I'm Dr. Maron Soribang Ziem, and I'll be leading the discussion on this. So briefly, we'll look at the outline of our presentation. We'll take an overview with some small anatomy, look at the etiology and risk factors involved in cervical cancer, something small about the pathophysiology, its clinical presentation, screening programs available, the workup of a patient, treatment, management, and the prognosis of the condition. So we all know the cervix is the cylindrical lower extremity of the uterus, mainly consisting of collagen fibers. And there are two main parts. There's a part of the cervix that is within the vaginal walls, that's known as the ectocervix. So this part is lined by non-keratinized stratified squamous epithelium. And then when we do the speculum exam, that's the part we see, which mostly has a pink appearance. So it has an opening in the center known as the external os. So through this os is a canal which connects the outside to the inside of the uterus. So within the canal, we have the endocervical canal, which is lined by the simple columnar epithelium. So there's a junction that exists between the ectocervix and the endocervix, known as the squamocolumnar junction, which is of importance when it comes to cervical cancer. So this is just a brief picture showing us the region of the cervix. So as one grows, the squamocolumnar junction also changes throughout the reproductive years. So in the early years, it lies at the external cervical os. That's just outside the ectocervix. However, as one grows through puberty, there's an extension of this zone. So the squamocolumnar junction moves closer inwards. So in adult life, it returns to the external cervical os through a process of metaplasia. So the area between the original squamocolumnar junction and the current squamocolumnar junction, where these metaplastic changes take place, is known as the transformation zone. So we can see here the arrow showing us the transformation zone. So we have the external os, then the ectocervix showing. So the arrow depicts that junction, that area between the old and the new squamocolumnar junction. So cervical cancer is the third most common malignancy in women worldwide, following breast cancer and lung cancer. It's the leading gynecological cancer in Ghana, and also the leading cause of cancer-related death among women in the developing world, which makes it very important to talk about as a public health issue, which involves all of us. The incidence of invasive cervical cancer is declining in the developing world as a result of screening programs that have been made readily available. So this cancer forms about 45% of all female cancers in the oncology unit of Confanoche. So how does this cervical cancer come about? It's caused by the human papilloma virus, which is the HPV. So the HPV infection is a prerequisite for one getting cervical cancer, and its mode of spread is through sexual intercourse. So it's shown that 99.7% of all cases of cervical cancer are through HPV infection. About 80% of sexually active women are HPV positive at some point during their lifetime. However, what happens with cervical cancer is that the infection takes a period of time to develop into a malignancy. So over a span of about 15 to 20 years. So with the initial infection, the initial process is usually transient and the patient is asymptomatic. So most women will end up clearing this infection. However, in some minority of individuals, there's a persistent genital infection, which predisposes them to pre-malignant and malignant changes over a span of 15 to 20 years. So there are several subtypes of HPV, over 40 subtypes. However, there are about 15 oncogenic subtypes those capable of causing cancer. But the common ones we see are the HPV 16 and 18, which are responsible for more than 70% of cervical cancer cases. Some of the risk factors, we have having multiple sexual partners. So what this means is that you are now predisposed to getting the virus from so many people. Introduction of coitus at a very early age, that's less than 16 years, increases the risk of a woman contracting the virus. Immunocompromised states, low socioeconomic status, male-related factors, like if you have a partner who is a high-risk consult, that means he goes around sleeping with other women, ends up carrying the virus and then infecting his partner. Smoking, among other factors, are also seen as risk factors for getting the condition. So with the pathophysiology, basically, what happens is that with persistent infection, the virus is integrated into there's integration of the viral DNA into the DNA of the epithelial cells. So with continuous infection, there are certain metaplastic changes that go on within the cell. So with continuous cell division, there's dysplasia. And over a period of time, there's disordered immaturity within the epithelium. And this is known as what we call the cervical intraepithelial neoplasia, or the CIN. So this metaplastic change that takes place is a pre-malignant lesion, which so is not yet cancerous. So the CIN can be classified as a low grade or high grade. So we have 3 stages: CIN 1, 2, and then 3. So if it gets to a point where this plastic changes breach the basement membrane of the epithelium, then cancer is diagnosed. And this usually takes place after about 20 years of initial contraction of the virus. So this chart just shows us the sequelae involved with developing the cancer. So from the initial infection, once it's not picked up through screening, there's persistent infection, and then the changes go on in the cells. You develop the pre-malignant lesion, and then after about 20 years, the cancer develops. So this is just a picture showing us the changes in the epithelium. So this is a picture that shows us from the normal cervix, showing the ecto cervix with the os. Then as the infection progresses, you see the ulceration on the cervix, and the lesion develops until finally becomes an invasive cancer, which may spread to other areas. So what are the screening methods available for us? We have the visual inspection with acetic acid or vinegar. So this one is just a simple procedure that can be done in the office setting. So with your speculum, you visualize the cervix, and then you spray the vinegar on the cervix. So after some few minutes, you inspect the cervix again. So if there are white opaque areas, which are known as acetowhite areas, they depict pre-malignant lesions. So from that point, then the next action can be taken. We also have similarly the visual inspection with Lugol's iodine or Schiller's test, which is also based on the same principle. However, you see a pale yellow color change if there are lesions. Then we have the pap smear, which is also readily available, the liquid-based cytology, colposcopy, and then the testing for the HPV DNA itself. So this is an image showing the white opaque areas on the cervix, known as the acetowhite areas. This is for the Schiller's test. Then with the pap smear, this is done under a microscope to visualize the changes within the cells. Colposcopy. Okay, so with the screening, what are the current recommendations? So it's recommended that for women less than 21 years, no screening is recommended for them. However, between the ages of 21 to 29 years, it's recommended that the pap smear, which is the cytology, can be done every 3 years, and the woman followed for within this period. Between the ages of 30 to 65, both the HPV DNA testing and the cytology can be done every 5 years. And this is preferable. However, if this cannot be done, the cytology alone is acceptable. And beyond the age of 65 years, no screening is recommended if adequate prior screening has been negative and high risk has not been identified. So what are the aims of treatment of our pre-malignant lesions? That's the CIN. So the aim is to effectively eradicate CIN to prevent its progression into cancer, to ensure that the post-treatment cytology is negative with subsequent follow-ups, and to minimize harm to the patient from the treatment. So the methods available for the treatment of the pre-malignant lesions, we have the excisional and the ablative methods. So we can do the loop electrosurgical excision or the large loop excision of the transformation zone. Could also do a laser excision, knife, laser or loop cone biopsy, and in the last resort, you can do a hysterectomy. The ablative methods, we have the cryotherapy, electrofulguration, cold coagulation, and laser therapy. So how does cervical cancer present? So in majority of women in the early stages, the disease is asymptomatic, but we can have women presenting with persistent vaginal discharge. So you are in your consulting room and a woman keeps coming with vaginal discharge, gets treated, but it's not going, keeps coming, and no one bothers to do a speculum exam to see what's going on. So persistent vaginal discharge, which can be thin, watery, or blood tinged. Abnormal vaginal bleeding, so intermenstrual bleed, postcoital, perimenopausal, and postmenopausal bleeding. And as the disease advances, then you can have pain, leg, pedal edema, urinary and rectal symptoms like dysuria, hematuria, rectal bleeding, constipation, and uremia and anemia. So how do we diagnose cervical cancer? You need a detailed history of the patients. You examine the patient thoroughly, which includes the speculum examination. An examination can be done under anesthesia. So to visualize the cervix, do your VIA using the acetic acid or the glucose iodine, take sample for the pap smear. But there are certain conditions that may mimic a cervical cancer, which makes it very important to always see your doctor to rule out some of these otherwise benign conditions. So we have cervicitis, a cervical ectropion, cervical tuberculosis, endometrial CA, pelvic inflammatory disease, and vaginitis. So these are some of the common investigations we do. So we run the basic labs, full blood counts, the chemistries, colposcopy or biopsy, can do a proctosigmoidoscopy, chest x-ray, abdominopelvic ultrasound, CT scan to help us know whether there's spread or the disease has affected other organs. So basically, we will look at the brief histology of the disease. Majority of cervical cancer cases are squamous cell carcinoma, with minority being adenocarcinoma and the mixed type. Squamous cell carcinoma because we said the ectocervix is non-keratinized squamous epithelium. And once there's metaplasia within this zone, we have most of these cancers presenting with these histological subtypes. And we also have the endocervical part being columnar. So some parts of the cancers may also present as adenocarcinomas. And we have a few percentage that present as mixed. So the mode of spread could be direct, that is to the surrounding organs, the uterus, vagina, parametrium, and the bladder and rectum. Could also have spread through the lymphatic channels, and then a late dissemination through hematogenous spread, and then the parametrium. So this is the staging of cervical cancer, which is into 5 main stages. So basically stage 0 is a carcinoma in situ. That is the metaplasia has not breached the dysplasia has not breached the cell membrane. So that is the cervical intraepithelial neoplasia. Within stage 1, we have a breach of the basement membrane. However, the carcinoma is confined to the cervix only. Then with stage 2, there's extension beyond the cervix, however, does not involve the side walls. So there can be involvement of the upper 2/3 of the vagina. With stage 3, there's spread beyond the cervix down to the lower third of the vagina, and with some pelvic sidewall involvement. Stage 4, there's extension beyond the true pelvis, and this can go on to involve the bladder, the rectum, or metastasis outside of the pelvis. And at this stage, that's when you have the urinary and the rectal symptoms. So these are just images that are showing us the various stages. So here we have the spread, involving the upper third of the 2/3 of the vagina, the parametrium. You have further spread down the vagina and the pelvic side walls. Then this one is involving the rectum behind and the bladder in front. So what are the treatment options available for the invasive cancer? So definitive surgery is usually limited to patients with low stage diseases. That's from stage 1 to 2A. We can do radiotherapy for high stage disease. And also there's a room for combination of surgery and radiotherapy, and also chemotherapy and then radiation. However, in far advanced cases, palliative care is done. So the treatment success depends on certain treatment success, and the option also depends on certain other factors. So the fitness of the patient, the age of the patient at presentation, the stage at which the disease has progressed to, the type of lesion we are dealing with, and the experience and resources available in the center where the patient is receiving treatment. So the prognosis of the disease depends on the stage, the age, and the method of treatment, as well as the experience of the surgeon or radiotherapist. So generally, in a 5-year span, stage 1 disease has more than 85% survival rate. Stage 2 has 50%, stage 3, 25%, to as low as 5% in stage 4 disease. So the World Health Organization came up with certain goals or targets towards the elimination of cervical cancer by 2030. And what the WHO is saying is that within this time, by 2030, 90% of girls should be fully vaccinated with the HPV vaccine by 15 years of age. So these are vaccines that are available currently, but not in all parts of the country. So it's imperative that by 2030, we have about 90% of girls fully vaccinated. Then 70% of women should be screened using a high performance test. That's why the main song we are singing this month is Screen, Screen, Screen. Once you screen, it gets detected early, then the appropriate intervention is put in place. Then the last target is that 90% of women who are identified with cervical disease are treated. So basically, the take-home message here is that the HPV infection, which causes cervical cancer, doesn't just happen overnight. It's a long-term process. 15 to 20 years is a very long time to get screened, so that the lesions can be identified for appropriate interventions to take place. So it's important that timely diagnosis is made, and this will ensure a very good prognosis. So we should all remember that January is a cervical cancer month, and we have to preach the message that every woman should get screened so that we save a life in this month. Thank you very much.
Excellent and very concise and straight to the point. So the floor is open for comments. I did put in the chat box that if there were any questions, people could put in there, but as of now, I don't see any comments there. Since we have a good amount of time to discuss around cervical cancer, and then we have our panelists available, kindly electronically raise up your hand. I will mute you, and then you can go ahead with your questions. So whilst we wait for the questions, I want to acknowledge the presence of my boss, the medical director at the Upper West Regional Hospital, Dr. Robert Amizia. I see him on the platform. Boss, you are very much welcome. I see you are so much interested in eliminating cervical cancer. Thanks for joining. Dr. Kelly Hartfield is the founder of Ghana Medical Help, and we thank her for making these presentations possible with the Zoom platform and the stipends that we now give to the presenters as well for their time and effort. So thank you, Kelly Hartfield, and all the donors who make this possible. I see my own sister Millicent, who is not a medic, but has joined in. I'm sure she advocates for women as well. Dr. Millicent, Professor Millicent, you are welcome as well. And I see a lot of my own colleagues, Dr. Nabil, and a whole lot of us in the department, Dr. Raymond, and the legendary Dr. Abisen, who is a gynecologist and joining us. So the platform is open, especially those of us who have insight into this condition. Could you kindly electronically raise up your hand? I would unmute you to help make these presentations rich with your expertise, with your guidance, with your questions and your comments. The floor is very much open. Please electronically raise up your hand and go ahead and I can unmute you. So there's no hand up yet. All right, so a couple of comments from the chat box. So the first one is, that was an excellent presentation from Dr. Iyaba. Yeah, I agree with you. That was excellent and concise and straight to the point. Abrifa Buzia, doctor asks that what age of girls are to take the vaccines? And what's the maximum age to take the vaccines? Which type of vaccines are given for males, if any? Okay, so this is a compound question, 3 of them. Dr. Ziam, will you want to take them? The age at which you should start vaccination and the type of vaccines that are available, and then if there are any vaccines for our male people so that then they don't transmit the HPV infection. If you want to take it, then you can.
I think once my boss, Dr. Gildas, is here,
All right.
Yes.
All right. So, Dr. Gildas, please let me unmute you and then you can go ahead. Please unmute yourself. I've asked you to unmute yourself and then you answer those questions. Yeah, I guess probably Gildas may be having some challenges unmuting himself. So, Dr. Ziam, do you want to give it a try?
Okay, so with the
age that we start with the vaccination.
Yes, so with the vaccination, usually it's available for both boys and girls, and as early as 9 to 11 years, the vaccine can be given. As to the different types, I think that one I'll have to ask my boss to help me on that. If you don't mind.
Hello.
Yes.
Yeah, I can hear you.
Can you hear me?
Yeah.
Yeah, I'm in a different meeting. This is Dr. Geldas, obstetrician gynecologist, head of department of obstetrics and gynecology, Upper West Regional Hospital. Yeah, so as Dr. SDM rightly said, the vaccines are available for both male and females for between the ages of 9 to 13, because we want to vaccinate these girls before they are sexually active. As we all know, the HPV virus, which transmits or causes cervical cancer, is sexually transmitted. So we have the Cervarix, which is mostly targeting the 16 and 18, and then we have the Gardasil, which adds 6 and 11 to the 16 and 18. But then, if you go to the Western country, we have the monovalent vaccine, which targets 9 of the high risk HPV viruses that cause cervical cancer. But currently, that is not available here. So we have the Cervarix and the Gardasil. But even though it is tailored towards 9 to 13, any woman at all in the age range, which we have realized is between 15 and 45, if you test for the virus and you are negative for any of these high risks, you can go for the vaccine because it will help you in the long run. But the target range is between 9 to 13 years before they are sexually active. And boys can equally be vaccinated. In Canada, they vaccinate both girls and boys. National vaccination program will definitely help, but we have not reached there yet. And we might never get there. But because Nigeria has actually introduced it, but I don't know why. It's a song that we've been singing for a long time. Maybe in future, we'll get there one day. But it's part of the primary prevention. All right, thank you. I hope the question has been answered.
Yeah, great, excellent. I think the other part of it was the maximum age that they can take the vaccine, the cutoff age.
Yes, so I think I answered that anyone can between 15 and 45 because that's a target where women of reproductive age that we are looking at. Even though we are vaccinating young girls before they are sexually active, if you also test for the HPV virus and you are negative for any of the high risks, you can go for the vaccine as well.
Okay. And then from Francis added that very insightful presentation. Could treatment cause early menopause?
Hello.
Like treatment of cervical cancer cause early menopause and possibly any infertility? Sorry, before Gilda, you take that question, I think someone wanted to talk. Please go ahead.
Yes.
Is it Dr. Jonathan?
Yes.
Yes.
Just to add to what Boss Gilda said, I think some few days ago the Director General actually announced that Ghana will so soon start with the HPV vaccination. Which would be to be forming part of our EPI. But as to which type of the vaccine that will be used, whether it will be Cervarix or it will be the Gardasil or any other, we are yet to know. And then when specifically it will be started, I am not sure. But I think they are ready to start now. So that we know, and then we'll take advantage of that.
Yes, that would be great if it indeed is ready to start.
Great, excellent. So fantastic, good news coming in from there. All right. So the other question was from Francis. He asked that could treatment cause early menopause and possibly any infertility issues?
Well, it depends on the stage of the cancer, as we've seen through the presentation. The early stages, normally we have some fertility sparing surgeries that can be done. Selective trachelectomy for them. This will require very high expertise. But for the advanced ones, of course, if you undergo radiotherapy and chemotherapy, it can definitely lead to early menopause and infertility. But we must remember that preserving the life of the woman is paramount. So whichever treatment modality as per the stage of the disease is recommended. Side effects will definitely come through, but it shouldn't matter because we are trying to treat the woman. So in early stages, from stage 1 to 1A, we can have fertility sparing surgeries. Some of them, even if you catch them early, like the 1A, you can just do a equalization around the lesion. In that case, you take out part of the cervix and then leave the woman's uterus for her. But if it's advanced stages, she has to undergo radio and chemotherapy. And sometimes, as we've seen, surgeries like radical hysterectomy and then pelvic lymphadenectomy. Hysterectomy means you are taking out the uterus. So it actually depends on the stage of the disease.
Great. So I think a take home like Dr. Ziam did put in is that screening extremely important, early detection extremely important, so that then the question from Francis you are asking, we don't wait till the late stage where a hysterectomy or even a radio or chemotherapy may have to be given in with possible fertility issue. The other thing, like Dr. Gilda did mention, was that, of course, life is of the importance. You need to live before you are fertile enough to give birth. So these are maybe things that may guide us whilst we take those decisions. From Salom Putin, thank you for the concise presentation. all cancer-causing HPV types covered by the vaccine. I think Dr. Gildas highlighted on that one, what is available with regards to the Cervarix, and then what's available elsewhere, like in where Kelly practiced in Canada, where there is more polyvalent than the limited number of coverage for our vaccination. So, of course, it just depends on the vaccine available. Dr. Gildas, Dr. Abisino, I don't know if you have any further questions on that before we take the rest of them.
Yeah, I think you answered it rightly. The Cervarix, the HPV type, subtypes, the most oncogenic one is the 16. So together with the 16 and 18, they cause about 70% of cervical cancer. And the Cervarix is targeted against that. The cancer, as I said, are 6 and 11. So there are about more than 10 high-risk HPV viruses. But currently, if you get the vaccine, the nano vaccine, which is not here, covers up to 90%, prevents up to 90% of cervical cancer. But I think covering up to 70% is enough to prevent cervical cancer in a lot of women. So currently, I'm not aware of anyone that covers all the 15 or so high-risk viruses. But as I said, the most oncogenic ones are covered, even by the Cervarix. Yeah, Dr. Jonathan, if there's anything to add.
I think you've covered it fully. The other part which I would take us back is the fertility sparing. In the late stage, if the woman still desire, though they will go ahead with the radio and all that, there's an opportunity to actually harvest. Some of the eggs and store, but this require high technology and equally require a lot of finance. And patients in our setup, tend not to benefit from this because of, their cost and also the technology that is required. So the main thing would just be the primary prevention. And that is where we should all focus on. Like you rightly said from the beginning, cervical cancer is a sexually transmitted disease. And from that point of view, it means that we can actually prevent it if we attach seriousness to it.
Great. Thank you, Dr. Bisson. Excellent. So the other questions, probably I'll just take those from Dr. Buzia. Management of pregnant women with cervical cancer with coexisting cancer or with carcinoma in situ. I frankly don't get it clear. So probably those who are pregnant with cervical cancer, what's the management? I guess that's what you're asking. Cervical cancer in a pregnant woman. So Dr. Gildas, Dr. Bisson, if you want to lead us with that.
Yes, so it's a good question. And a pregnant woman can actually get cervical cancer. But as usual, it depends on the stage and then the pregnancy, how advanced the pregnancy is. So if it's early pregnancy, there's no point in keeping the pregnancy. You have to terminate and then you treat the woman based on the stage of the disease. If it's mid-trimester, you can wait for up to maybe 2 months. That's if you are stretching it. For the fetal lungs to mature, then you deliver by cesarean section, not the normal cesarean section. Of course, you do what we call a classical incision and deliver the baby before you now treat the woman. You can do your radical hysterectomy as per the stage. And then if there's a third trimester, and fetal lungs are also mature, you have to deliver the baby and then treat the woman, either surgically or through radio chemotherapy. So it actually depends on the stage of the pregnancy. In early pregnancy, it's advised to treat.
So,
yeah, thank you.
All right. Great. Thank you. Yeah, so from Salon Putin again, can long duration of the oral contraceptive pill be considered a risk factor?
Yes, it's actually a risk factor. We all know, as Dr. Ziem rightly put it, is estrogen. Estrogen will cause, for instance, what we call the transformations will actually have 1, 2, 3. The 3 means that it is inside, unless you manipulate it before you can see it. And that's where the cancer occurs. So what these COCs do is that they can lead to maybe a TZ3 becoming a TZ2. And once the transformation zone is exposed, there's a risk of getting infection from the HPV virus. But then this can take a long time, for instance, more than 5 years before it can get that risk, which is actually minimal, but it's there. We can't run away from it, it's there. And once you stop taking the COCs, within 10 years, your risk goes back to the normal woman who is never on COCs. But then we have to look at, if we go about preaching that COCs causes cervical cancer, I don't think it will help. One, the risk is very small, almost negligible. Two, COCs themselves also protect against certain cancers like ovarian and endometrial cancer, notwithstanding the fact that they are used for contraception. So I think it's a place that we have to be careful about preaching to our women. If not, they will not take it. The important thing is screening, whether you're on COCs or not. You have to screen. And when you screen and we get the pre-malignant lesions, we'll treat you as such. So yes, it's a risk factor, but it's a very negligible one. And sometimes the benefits outweigh the non-benefits. Thank you.
All right, great, fantastic. David Pusin, would total hysterectomy be recommended in the early stages of cervical cancer?
Yes, it's part of the treatment, but we don't quickly go to do a hysterectomy for such women. Of course, you have to make sure that you've really staged the woman properly. But you have to also put into other factors like, has she completed a family, her age? I mean, a woman who has 10 children and is 45 years old, and maybe you get a stage, the early stages, or even CIN 2 or 3, that's the pre-malignant stages. Why not? So hysterectomy is part of the treatment, but it's also depending on the type of hysterectomy as per the stage of the disease. So it's not just a simple hysterectomy for some of them. Some you have to do pelvic lymphadenopathy and all that. And some still have to go for chemo radiation even after the surgeries. So yes, hysterectomy is part of the modality of treatment for pre-malignant lesions and early stages of cervical cancer.
Great. I think still from David. Is that famous?
Pardon?
It's asking whether it runs in families.
No, it doesn't. But one of the, on the lighter side, one of the...
Is that family predilection?
No, there's no familial. But one of the risk factors is low socioeconomic status. So maybe it can run in families in that regard. It's just a joke.
Yeah, so just a follow-up. What for the cervical CA?
Pardon?
I was just asking, any particular leads from the low socioeconomic status? Is it by way of what they eat or by way of
No, it's not by
life?
what they eat. We all know the screening. That's why the screening is very difficult, even though the screening is expensive. I mean, for a lot of people. So most people don't screen, and they will not, the pre-malignant lesions will not get picked up. Most people in low socioeconomic don't even go to hospital unless it's necessary. And the cervical cancer is a very, let me put it, silent disease. By the time the symptoms become overt, it has spread to the later stages. Some just come with repeated vaginal discharge, painless. So they hardly come to the hospital. And of course, girls in low socioeconomic status is unfortunate, but are likely to get engaged in sexual intercourse earlier than those who are not from low socioeconomic backgrounds. So these are the factors that influence. I mean, so it's tied back to early sexual intercourse, multiple sexual partners, and then lack of screening. The screening alone is going to eliminate cervical cancer in the Western world by 2030. That's why it's a very important date. So it has been found that most cervical cancer deaths by 2030 will be occurring in fact, 98%, if the statistics are right, will be occurring in low socioeconomic countries like Africa and South Asia. So these are the main reasons why it's a risk factor.
Yeah, that's unfortunate. Let's hope that the awareness gets out there, and then, of course, governments and other people make commitments. Like we heard Dr. Bissell mention about the Ghana Health Service boss talking about the vaccine going to be available as well. So on the vaccine, Sani asked whether it's available at the Upper West Regional Hospital, the Cervical
No,
or any
it's
of
not.
that.
It's not.
Great. So this is not available. I'm sure we'll make plans.
But we are working towards getting it. So.
Exactly. All right. Okay, so I think this is all of it from the questions. Albert put in very concise and excellent presentation, and he's asking us to consider working on these presentations so that they can start receiving CPD points. They are very impactful. Thank you, Albert. Yes, that's true. You know, with CPD accreditation, there's a lot of money, financial muscle involved in accrediting them. What we try to do is to accredit some, especially those that are practical based, so that then we cannot accredit individual programs like this because it will be so much on us for some to be spending more than 20,000 Ghana cedis having to do this, and that's a lot of money. So we will accredit some of them, especially those that are practical based, and you'll be able to get points from those. The intent is not only on CPD acquisitions, mainly towards practical development, it's mainly towards skills acquisition, mainly towards knowledge transfer, and more importantly, also towards establishing a link, a chain of referral for mentee-mentor relationship and all of that. So these are the key points, but definitely very true. We're happy that it's making the impact. We would accredit those that would be having either as hybrid or as practical sessions. Also, I know that the Upper West Regional Hospital on an annual basis does organize CPD programs, and this year we're doing a similar one that will carry about 30 CPD points as well. So that in itself, that alone will be all that you require for the entire 2024. But of course, then those that will add in from Ghana medical help as well, I'm sure you will get more than enough points for 2024 if really you follow our community service agenda. And like at the closing remarks, you will hear about something that we are bringing up called the maternity service agenda. I'm sure you will be good to go. You will not need to travel to Accra or anywhere to have your CPDs or any of that. If you are in WA or wherever you are in Northern Ghana, you have the maximum points, which being 15 in the comfort of your home or coming to the hospital to have the practical sessions. So thanks. So this is all for the comments in the chat box. I look forward to having one or two questions if you have any, and then we can, yeah, Dr. Hartfield, please go ahead.
Thank you. Thank you, Dr. Akatiba. That was a great presentation. Thank you so much. I'm based in Canada, and I don't have a question as much as a comment that just is an interesting add-on to today's topic. So in Canada, it's really actually, there's a lot of similarities, but certainly more access to the vaccine, but still a lot of resistance to it because it's a new vaccine and there's a lot of vaccine skepticism here. But in Canada right now, there's a breakdown, there's a breakdown where there's a massive shortage of access to physicians. So people aren't getting cervical cancer screening with their PAPs. And it's become quite a big issue. Instead of doing it every 3 years, people are going 5 to 10, and there's just no way without going to a doctor that they can get a PAP. So one of the things in Canada that's been worked on for the last 15 years that's finally being rolled out where I live, which is in British Columbia, is the HPV vaginal swabs, which are self-swabs that get sent to the individual patient's home, that it's shown they're just as accurate in terms of swab results if they do it themselves versus if a physician or a nurse does it. And the swabs, these HPV swabs, are just vaginal, not cervical, obviously, and they have a very high negative predictive value, which means they are significantly more sensitive and effective at identifying people at greater risk of developing those precancerous cervical lesions than the Pap test. Actually, the Pap test doesn't have that high of a negative predictive value, which is why actually you have to repeat the pap test every 3 years versus because the HPV, the vaginal swab is so high in the negative predictive value, it's only done every 5 years. So it's something that's just interesting to know exists and is being rolled out and will, you know, eventually make its way ideally, because the access, it's going to be a game changer. I mean, PAPs are uncomfortable. People are afraid of them. They require equipment. They require time. So you know, it's always a drag here, but it's really, really exciting for me as a family physician who does a lot of women's health and maternity. This is something I'm really excited, because I think the compliance with screening is going to go up dramatically. So just wanted to add that in, because I don't know if anyone's ever heard of that or known about it, but it's just interesting.
Yeah,
Yes.
excellent. And yeah,
Dr.
Gildas,
Katuba.
please go. Yeah.
So thank you, Dr. Kelly. I mean, from what she's saying, access to even screening in Canada, there's resistance and all that. And yes, the PAP, even without that, expensive. I mean, and the HPV as well. We don't even have that testing kit in this part of the country. And I mean, in the national guidelines for Ghana, actually, none of this is actually there. They are saying that we should, that's 2005. I don't know if that has been updated, but they are saying we should screen women between the ages of 25 to 45 with the visual inspection with acetic acid. And then we treat positives with cryotherapy. And then do pap smear for those who are above 45. I mean, so this statement is riddled with lack of money. Let me just put it that way.
Yeah, a lack of evidence.
Yes, we just use the VIA. That's what the national guidelines telling us to do. So there's not even a place for pap smear and all that. And then the WHO in 2013 actually said we should, I mean, what we presented was the ACOG guidelines that you should start screening after 21 years. But the WHO actually recommends that we screen after 30 years. And that we should look at the age groups that are mostly affected. So it's more like a targeted screening. And of course, they even recommend that, I mean, we should target women between the age of 30 and 49, because most people with cervical cancer are within that age range. And they actually say even one screening in a lifetime is beneficial, because the first time you might diagnose somebody is just passing a speculum. So yes, I agree with you that it's a challenge, but I think with time, things will get better.
And hopefully the cost will get driven down, certainly as technology develops. Interesting, in Canada, it's from ages 26 to 69. And somebody did ask a question, I don't think it was answered, about why don't we screen earlier, like if teenagers? And just to, I don't think that was answered, right, Dom?
Yeah, I think he was more rather asking when we should start the vaccine. Maybe I didn't see the question if it was regards to why the vaccine is not given in teenagers, like those who are yet to achieve a coitus or any of that. Yeah, but you can address that. Yeah.
No, we said the vaccination is from 9 to 13 years. That's, I think it was answered.
I think someone, I thought they asked, no, just why don't we screen, like do PAPs younger? But
so the screening, as we rightly presented also, the HPV for younger women, especially women below 25 years, the virus, 80% will get HPV sometime in their life once they become sexually active. But 90% of this is cleared. So if I test today I'm HPV positive, in a year's time, if I'm a young woman of 22 years, the virus might not be there. So as I said again, all this, I don't want to use the word wastage, but it's mainly the reason why younger women are not screened, because they have the ability, especially if they don't have reduced immunity. If they are HIV patients who are 90 years, they have to screen every year. But if you are a normal, healthy woman, you are likely to clear the virus within a year. So that's why younger women are not, most guidelines don't include younger women in screening modalities.
Thank you, Dr. Gildas. Perfectly put.
Fantastic. Yeah. So yeah, I don't see any other hand up. I think we almost on the hour. We usually don't want to take much of your time, and so want to keep to our time. We usually start exactly on the dot and try to end just before or at 4 p.m. I think you just have about 7 minutes to go. Dr. Gildas, your closing remarks. So whilst we wait Gildas to come in, just a quick one. In the chat box, you realize I put in a link that takes you to a simple survey for us to evaluate today's presentation, especially today being a unique one, getting out of the domain of medicine. Let's see how we've fared with this presentation, and more important, let's have your inputs for future presentations, what we should consider doing. As well, if you need the slides, you put in your email address and the slides will be sent over to you so that then you can go through this if you did miss some parts of it. Also, you realize this is being recorded and will be put on our channel on the YouTube so that then you can have access to it as well. So these are the ways that we make the various presentations available 24/7 and at your comfort. Dr. Gildas, please go on.
Yes. Thank you, Dr. Katuba. So as we've seen in the presentation, cervical cancer is a major cause of cancer death in women in developing countries. Yes, amounting to about 85% of the worldwide cervical cancer deaths. The WHO estimates that over 500,000 women will be diagnosed with cervical cancer yearly, with the majority between the ages of 15 to 45. And it's estimated that by 2030, 98%, as I said earlier, of cervical cancer deaths will occur in developing countries. This disparity can be explained by the lack of screening and vaccination. And as I said, it's expensive, but VIA is an alternative to pap smear in low resource settings. An important instrument in the global fight against cervical cancer is the implementation of HPV vaccines in low-income settings. And according to Dr. Abesik, this will be rolled out very soon. I hope it will be in the next year and will not fizzle out after the elections. And then efforts to decrease the cost of this vaccine could result in increased use in developing countries. But we must also know that even though it will take several decades to see the impacts on mortality, this will be an important milestone in overcoming the global cervical cancer burden. No woman should die from cervical cancer. The latent phase is so long, 10 to 15 years. There's no point in dying from it. And the pre-malignant lesions can be treated and you will be free from cervical cancer. So in this month of cervical cancer awareness, I would just encourage most ladies or all women
definitely
to get screens. Thank you.
Thank you. Fantastic. Thanks for a great job. And thanks, Dr. Ziam, for an excellent job as well. Dr. Abesim, any closing remarks, any comments? I think Dr. Abesim's microphone is muted. Yeah, so just to say that, of course, we've learned a lot today. I definitely have, because definitely this is not in my domain. I've learned a lot about cervical cancer today. I would encourage early screening for all my patients and all those that I know. I guess you also do the same wherever you are, and hopefully with policy changes at the Ghana Health Service level, like we heard from Dr. Abising, hopefully this would be a game changer in terms of cervical cancer. We thank you, Dr. Kelly, for your comments as well and for waking up early to join us in this presentation and for all you do to make this possible. We are grateful, Dr. Robert, the head of our hospital, for joining us as well. And to Dr. Abising, the obstetrician gynecologist specialist who also joined us with fantastic insights. And a big one to you, Dr. Ziam, for taking all of us through this. We are grateful and we are thankful, more importantly, to you, those who have all joined us, the over 70 participants that we had. We are grateful for your time. We hope you've learned something. Next week, we hope to come your way with one of the presentations again. We'll put it up on the various platforms as usual. And like I mentioned, if you have any topic, any particular sector that you may have gone for a refresher training, you may have some expertise in, please make yourself available to us, and then we can teach each other, we can learn from you. Because like they say, knowledge is not in one person, and definitely together we would be able to improve the health system delivery in the Upper West, in the Upper East, in Northern Ghana, and in the 5 regions of the Northern Ghana and elsewhere. So please make a point to join us and to make your expertise available. Thank you so much for joining us for this week. We'll be able to do this in less than an hour. Hopefully next week we'll do the same. So enjoy the rest of your day, and God bless all of us. Bye-bye.